Great. I just wanted to say hello and welcome everybody. I'm Lisa Monroe, the Tompkins County Office for the Aging Director. Just going to start by giving you a little bit of background about our presentation today and our age-friendly process. In May 2015, Tompkins County and the City of Ithaca were accepted into AARP's network of age-friendly communities. And in November 2019, Tompkins County was one of 3 counties in New York State awarded a grant from the Health Foundation of Western and Central New York to develop a center for excellence, an age-friendly center for excellence. This initiative is designed to help communities and local governments incorporate healthy, age-friendly principles into relevant policies and programs which directly benefit the community. Today is the final workshop in our 4-part virtual workshop series. The recordings of our previous workshops can be found on our website, and the link will be provided in the chat. I want to thank Dominic Recchio for once again assisting us with the entire series, but also today. He's our communications director for Tompkins County and helped us all along the way to get the invitations, to helping us plan everything. So we really appreciate that, Dom. Also want to thank the Age-Friendly Steering Committee core team who planned the workshop series, which is Karen Bullis, Terry Reineman, Esther Greenhouse, and Vanessa Wagner. So this workshop also will be recorded and uploaded to the Tompkins County YouTube page. Please use the chat box to ask any questions or to provide any comments along the way. We'll try to address them in the chat, or we will definitely address them in the Q&A session. Today's workshop is entitled Age-Friendly Communities, Health and Wellness, and I am first on the agenda, so I will start presenting here in just a moment. I'm going to start sharing my screen. Okay, just a moment. If someone can give me a thumbs up that they can see this or say something.
Looks good to me.
Okay, wonderful. Okay, so I am going to talk about Tompkins County Office for the Aging's planning that we do for healthy aging and wellness through an age-friendly lens. Wants me to click through here. Interesting. So, okay, this is just a visual representation of Governor Cuomo's initiative that was launched in 2017 to advance health across all policies. You'll probably see this a little bit throughout our presentations. I know some of the other folks that are going to be presenting will share some of these insights from their perspective as well. Health across our policies was really created to identify and strengthen the ways that all state agencies can have a positive impact on health. You can see the core of this visual is, improving the health of New Yorkers. It's really a collaborative approach that integrates health considerations into policymaking across all sectors to really improve the community health and wellness, recognizing that a community's greatest challenges are often linked with other societal issues and not just about healthcare. As it says here, 80% of a person's health and well-being is determined by factors beyond healthcare. And I know Nicole will specifically address this in her discussion with social determinants. She'll discuss it further in her presentation. So here's another visual. I like these visuals. I think it is a great representation of what New York State is trying to do and with their approach. This was signed, Health Across All Policies was signed into law in 2018 through Executive Order 190, incorporating these Health Across All Policies into these state agency activities. Last workshop, we dove a little farther into smart growth principles, and Sam will speak further to the prevention agenda. I wanted to more or less talk about the age-friendly piece of this, and that these domains these components really work together to achieve health across all policies. And these age-friendly domains represent and focus on areas that influence health of a community and how they affect the quality of life of people of all ages. If you want to know more about the health across all policies, age-friendly road, there is a roadmap. I think Karen is going to share that in the chat at some point, and it can help communities to include these age-friendly principles into their planning and their actions. Okay, a little bit about demographics. I think most of us that are on this call have heard that the United States is rapidly aging. I think we all are pretty aware of that, but I'm going to remind you of a couple statistics that by 2030, 1 in every 5 people in the United States will be 65 or older. And by 2035, the number of 65 plus adults will be greater than children under 18. So those are some strong statistics. And I'm trying to click through here and it's not letting me. Okay. Yes, so a visual of Tompkins County. If this is, if you're not from Tompkins County or if you're a future viewer of this presentation, we're located at the tip of Cayuga Lake. Tompkins County is part of the Southern Tier Economic Development Region and in a 5-county Southern Tier region established by the Department of Health along with Broome, Shenango, Delaware, and Tioga counties. We have 9 towns, 7 villages, and 1 city, population around 104,000. 30% of this population is college students and 30% live in the city, and 14% of the population is over 65. This piece of it is a little bit more about population trends. I like to show this because I think it's a pretty significant jump, significant decrease and a significant increase. In the next 25 years, you can see that the 18 to 14 population will be decreasing in the next 25 years, over 8,000 people, and the 60 plus population will be increasing by over 7,000 people. And this really was the beginnings of our age-friendly planning. Knowing this, this rapid aging, the population increasing over the next couple of decades, is why we began to think about this and plan more in 2015 when we first started age-friendly planning. We knew we needed to prepare and plan for the aging population. We also wanted to highlight some of the efforts that were already happening in the community and to engage local residents in the process. We wanted to create a supportive social, physical environment to support health and well-being really across the lifespan. Okay, so needs assessments through an age-friendly lens. I've got our logo and the health department's logo, just to kind of highlight that, state agencies, county agencies, city departments are always required to plan. We continue to plan as a requirement, typically of our funding that we're receiving. And, the health across all policies is really trying to push us into, cross collaboration, cross agency collaboration, similar to that image we shared earlier. As far as the Office for Aging, the Older Americans Act and New York State regulations require that we, area agencies on aging, we call them AAAs, develop and submit an area plan through the New York State Office for Aging. Each AAA receives resources to fulfill this role, the planning and coordination of it. The development of the plan is a responsibility and a requirement. In New York State, it's done in a 4-year period, and this is updated annually. The plan has to describe how we will provide a comprehensive and coordinated system of services for older adults and how it will comply with the Older Americans Act. We do this a number of ways. We have public hearings, we continually collect data, we information gather. All this informs our plan and is updated annually, as I said. In 2019, we conducted a needs assessment, and we really wanted to consider our age-friendly work and try to approach it through this age-friendly lens. We not only used other information, we used the community needs assessment, community health assessment from the health department, and we use survey data, our census data, to provide additional insights, but really we wanted to make our questions through the lens of age-friendly, and we kind of broke them up by the domains of age-friendly, which helped us to just really drill down to what was important to people and how and what they knew about age-friendly. So our assessment, our needs assessment was conducted in 2019, as I said. These were the needs assessment areas that we focused in on and tailored our questions around. This was given to residents of the county that were 60 plus and or caregivers of older adults that were 60 plus. So this is just a high level breakdown of the top 10 issues that came out of our assessment, and the assessment is on our website. That could also be provided in the chat at some point if you want to read the full assessment, but these are just the top 10 high level issues that came out of this. And you'll see this top 10 perceived issues of our older adults. Really, the way the question was posed is that this is an important problem for older adults in my community. So it wasn't necessarily asking them if it was a problem for them. It was what they perceived as the problem in the community. This was important to us. These thoughts and values, they really help us inform how we do outreach, how we provide information and educate people about the resources that are available in the community. The survey respondents frequently selected important problems in their community surrounding housing, transportation, being socially isolated. These issues were also mirrored in the personal concerns that I'll share that in the next slide. And they were identified for the survey respondents of personal concerns for them, including insurance and Medicaid issues. So this slide just represents the top 10 issues for people, personal and caregiver issues that is a concern for that person or the person that they care for. So you can see they are mirrored, but there's a little bit more about some insurance and subsidy, being able to understand that kind of thing, taking advantage of what's available to them, understanding Medicare. And rather than just affordable housing in general, it was more specific to performing home repairs or maintaining their homes. So this was another question we asked, which was a little bit surprising. 40% of the respondents indicated that they're familiar with age-friendly and livable communities, and 61% said that they were aware of COFA's programs and services. So for me, this was a little low. I knew that we had an opportunity to do some more work around informing and educating people not only about the importance of these practices and principles, but showing them some real examples of how they can work to make their communities more age-friendly, and also what we do as COFA. And this is part of the reason why we are having these trainings as well. We continuously plan and shift as needed as we plan for older adults in the community. Our programs and services for health and safe aging to meet the needs, we continue to look at that through an age-friendly lens. And finally, this is my last slide. Moving forward, age-friendly is a 5-year cycle. So we've gone through the first 5-year cycle. We're on the second 5-year cycle right now. We're in the planning phase. As you can see from this, the arrows that go across, the orange arrow is the planning phase, 1 to 2 years. And then the 3 to 5 year green arrow is where the implementation, the evaluating our progress, and the continuous improvement happens. So we will be continuing to work on our age-friendly efforts, encouraging system level policies and practices, seeking funding to support what we do for age-friendly, pulling in cross-agency relationships, collaborating, and working towards an age-friendly, livable, it really involves this continual process of improvement and checking in and figuring out. I mean, as we all know, we just went through a pandemic, which completely changed the way the needs were for people in the community. So you have to shift and address those things, and that's what we continue to do. So I am going to try to stop sharing now. Okay. And I am going to pass it over to Nicole Zulu. Thanks, Nicole.
Yes, thank you, Lisa. All right, and let me go ahead and share here. Share my screen. Share screen. There we go. All right, and hopefully let me know if you're not seeing that correctly.
Looks great, Nicole. Thank you.
Great, thank you. All right, thank you everyone for joining us today. I'm excited to be participating in this workshop series. So my name is Nicole Zulu. I am the Director of Health Planning at the Human Services Coalition, and I'm going to talk today about the importance of social determinants of health when we're talking about creating age-friendly communities. So before we get to the social determinants of health, first let's talk about what is health. So according to the World Health Organization, health is defined as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So when we're talking about creating age-friendly communities, we're looking from birth to aging adults, thinking about the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being. And again, the healthy development of the child is a basic of importance. So we want to make sure we're fostering communities that are promoting healthy development of children and the extension to all peoples of the benefits of medical, psychological, and related knowledge is essential to the fullest attainment of health. Now, this is important when we're considering the social determinants of health, right? Because we're not only thinking about physical or mental health, we're thinking about all the different components that contribute to health outcomes. And when we're thinking about health outcomes, we're talking about mortality, morbidity. So this is the occurrence of disease, illness, or life expectancy, the amount of years one is expected to live. Healthcare expenditures, how much people are paying for their healthcare costs, your self-identified health status, and any functional limitations. So first here, speaking of economic stability is one of the predominant social determinants of health. And of course, one of the things we think of first is employment, jobs, right? Having low unemployment rates and thinking about income, right? We want to have a community that is affordable to live in, that has living wages. When we think about Tompkins County, we actually have the 6th highest rate of percent of people living in poverty in Tompkins County. And then also this is related to expenses, right? Having high cost of living, which also contributes to your amount of debt, which makes what limits your ability to save and buy homes, buy healthy food, and also can lead to high medical bills. We are one of the few countries where people filed bankruptcy as a result of medical debt. Moving on to neighborhood and physical environment. That's something that has been spoken about a lot in these workshop series, the importance of creating housing and neighborhoods, walkable streets that are accessible to all, especially when we're talking about mobility issues, housing that is affordable, accessible. Of course, these are issues that are more difficult in more rural areas or low income areas. Transportation, having access to affordable public transportation. Again, this is an issue in more rural communities. Having safe neighborhoods, having low rates of crime, having green spaces with playgrounds. Again, when we're speaking of age friendly, we want to see spaces that promote child development all the way to aging in place. So having those green spaces and walkability, is for people that have transportation issues, is it easy, accessible to the green spaces or healthy food, for example. And then moving on to education. Education is an important component of the social determinants of health. So for example, children who are born to parents who have not completed high school are more likely to live in an environment that poses barriers to health, such as lack of safety, exposed garbage, and substandard housing. They are also less likely to have access to sidewalks, parks, playgrounds, recreation centers, or a library. So having high quality education. And again, when we're talking about low income, there's a lower tax revenue, which might contribute to having lower performing schools. which leads to low rates of literacy, poor language development skills. We want to have universal access to pre-kindergarten, early childhood education. And we want to make sure that it's accessible and affordable to access vocational training and higher education. Moving on to food, food's very much tied into, especially physical health. So hunger, again, related to low income, but also access to healthy food options. Again, in rural and low income communities, we're seeing, more food deserts. So the lack of access to the healthy options. And then community and social context, very important, creating age-friendly communities, making sure there is social integration for all age cohorts, and as well as support systems, and providing opportunities for community engagement across the lifespan, and especially throughout the cohorts, creating communities that is free of discrimination and is not increasing stress. And then finally, the healthcare system. And when we're thinking about the healthcare system, health coverage, right? Health insurance is one of the predominant ways to access health coverage, although it doesn't guarantee access. It is one step in our country. And the most recent rates is we have an uninsured rate around 3.5% in our county, which is lower than the state rate of around 5%. But that's still several thousand people without health insurance in Tompkins County. Looking at provider availability, are there primary care specialist hospitals that are easily accessible? Again, more issues in low income and rural communities. And providers who are providing services in different languages, whether you're having providers that speak different languages or you're using an interpreter service, and also providing culturally competent services is very important in providing high quality care. And of course, when we're looking at care, it's not just about how much care we're giving, it's about the quality of care. So these all work together to create age-friendly environments. We're talking about the social environment, municipal services, and physical environment. And together, these all come together hopefully to promote an equitable, age-friendly community. And equity is the absence of avoidable, unfair, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. So this representation here, this picture, I think really represents why it's important when we're thinking about the social determinants of health and nurturing everyone's health in a community. So our environments cultivate our communities and our communities nurture our health. So on the left-hand side, we see when inequities are high and community assets are low, health outcomes are worse. So we see here on the left, we have high rates of unemployment, poverty, poor quality schools, institutional racism, discrimination. And with this, we see we have a tree that is not flourishing. It's leaning to the side, and we're having high rates of poor health outcomes like depression, stress, violence, smoking, substance use, obesity. Then on the right-hand side, when we have where inequities are low and community assets are high, the health outcomes are best. So we're having high quality schools, access to healthy foods, low rates of unemployment, health insurance, and access to healthcare, quality housing. We're seeing a tree that is growing and flourishing, and we're seeing a low rates of those poor health outcomes. So when we're talking about the social determinants of health and all those different categories, we want to move to from the top left-hand corner of inequality to the bottom right-hand of justice. So on the top left-hand, we're seeing inequality. So we have unequal access to opportunity, where we see the one person is having things fall to them and the other person, nothing is happening for this. So this is an unequal system here. On the top right-hand, we have equality, evenly distributed tools and assistance, where this is where we're giving everyone the same amount of everything. Whereas the person on the left is able to access these resources, the person on the right still cannot access them because equal is not equitable. So our bottom left-hand corner, we have equity, where we customize the tools that identify and address inequality. So the person on the right now has been lifted higher to reach those resources. However, we still see the person on the left is able to access more resources. So this is where we want to move to justice. And social justice is the view that everyone deserves equal rights and opportunities. This includes the right to good health, and to assure that everyone has the opportunity to attain their highest level of health, we must address the social determinants of health and equity. So in this picture, we see the tree has been fixed, the system has been fixed, so that they're both able to have equal access to the same resources because we fixed the system. And so when we're talking about the social determinants of health in our county, in Tompkins County, 2-on-1, which is an information referral resource program here at the Human Services Coalition, is a really integral part of that. So if there are any health and human services needs, you can contact 2-on-1, and they can provide information or referrals for a lot of those social determinants of health that we've discussed, whether that's housing, public transportation, food insecurities. We have programs here at Human Service Coalition that they can make an appointment for with our health insurance navigators who can help enroll in health insurance, or community health advocates who help assist with any health insurance issues, regardless of your health insurance, whether it's Medicare, Medicaid, VA, employer provided. So they're a very integral part in our community in making sure we're addressing those issues of social determinants of health. And there are many ways to contact 2-on-1, as you can see here, via telephone. The easy way in Tompkins County is call 2-on-1 or a toll-free number. You can use text message, online chat, email, or just do a web search. So I want to thank you very much, and I'm going to pass it on to Sam Hilson at the Tompkins County Health Department.
Thank you, Nicole, and thanks for having me today. I'm going to go ahead and share my screen now. Okay. All right. Okay. All right. So today I'm going to share some information about the Community Health Assessment and Improvement Plan as part of this training workshop today. And I am the Director of Health Promotion here at the Health Department, and also the Public Information Officer. So the Community Health Assessment is something that is required by the New York State Department of Health for every local health department to do about every 5 years. And it's really meant to be this picture of the health landscape at that particular time. It's a description of the community. It gives the health status based on data that we have available. It identifies the main health challenges and also the assets and resources that we have in our community. And then that health assessment then guides us to make and choose priorities for our improvement plan and what we will be working on as a community for those next couple of years. So the Community Health Improvement Plan actually is more like a work plan going forward. So the New York State Prevention Agenda, which Lisa mentioned in her presentation, is really this blueprint for local health departments to think through as they determine how to improve the health and well-being of their communities and promoting health equity in their population. So the prevention agenda, this most recent version, the state updates it every cycle of the community health assessment process. And this most recent version really has made big steps for the state. I think that it really has a focus on social determinants of health that Nicole was just speaking about, and really a shift from mental health and substance use disorders to this concept of well-being. And I think that that's a real critical part of this latest version of the prevention agenda. And also in Lisa's presentation, she had the graphic of the 3 overlapping frameworks, and that again includes the SMART growth principles, the 8 domains of livability, and this prevention agenda, and that together they are really the impetus to create this healthiest state across the lifespan. So these are the 5 priorities that the state has identified: chronic disease, the healthy environment, women, infants, and children, well-being, and preventing communicable diseases. So, and I'll say that we did this assessment and improvement plan just prior to the COVID pandemic. So, so we submitted our assessment and plan in December of 2019, shortly before sort of the rise of COVID. So, so I'll talk about that a little bit later, but just to give you that context. So I wanted to share with you the process for the community health assessment, that it was about a year-long process that involved convening a steering committee of some different partners, some of whom are on this call. It involved a community survey that went out to the general public. And people could respond online. There were paper versions. Some of our different community organizations assisted with that. We had interviews with different key partners in the community. We had input from our senior leadership team here at the health department and mental health departments. And then we also did a review of data that's available at the state level. And we held a few focus groups for community members that focused on some different questions around food insecurity, around prenatal care for mothers and children, and around mental health issues. So again, these primary data sources that we collected involved, our local data collection that we did during this time period. And the survey that we did, really similar to the needs assessment that Lisa spoke of, was also about perception of health. So how people think about their own health. And then I mentioned we also review a host of secondary data sources or larger data sets that are available at the state level or federal level, like the census data. So I'll mention again, you're going to hear it, I guess, in all of our presentations today, the importance of thinking broadly about health and these social determinants of health, or the factors that affect people having positive health outcomes and perceptions of their health versus negative perceptions and outcomes. So this is a graphic that shows the social determinants of health that Nicole spoke about. And I also put up that health across all policies graphic as well, because they really are very similar, that they're pointing out and addressing many of the same issues. These different factors and conditions that we all experience, and some have negative impacts, and others can have very positive impacts. So I wanted to give one example based on some of the data that we reviewed and collected related to these social determinants of health. So I'm giving one example about housing, and interestingly, that housing is not specifically identified as a priority in the prevention agenda. But again, I think that a lot of this is thinking about, as we're planning for community health and wellness, is thinking about how, even though the health department does not, have specific programs or authority over housing per se, that it's really important for us to work with our partners who deal more with housing, and also consider the effect of housing, especially on people's health. So, so here is some data about Tompkins County, about owner-occupied housing versus renter-occupied, and then showing that, a large percentage of our housing is built prior to 1979. So it's older housing stock. And there's a myriad of issues that can come with older housing stock, including lead paint, for example, and various upkeep of older houses. This is a quote from one of our interviews that we held during our data collection process. So I'll let you read that about insecure housing and the effect that that can have. And then this is from our survey, again, about how people perceive or think about their own health in relation to other factors. So this pairs how people responded about their physical, dental, mental health, and overall health, and then cross-tabulated with the type of housing that that person identified that they live in. So I just want to point out that our scale for these questions is a little bit odd, because one is actually feeling good or, better or excellent about someone's health. And 5 or 4 at the top of this graph is actually less good, or, not as positive about somebody's health. So you can see that individuals who are homeless also rated all of these health factors as being low. And then subsidized housing is the gray, and renting is orange, and then blue is owning your own home, and that you're rating all of these factors of health in a higher or more positive way. So after we reviewed all of what we found for the community health assessment, we moved on to choosing what priorities our county would actually highlight during these next few years for the community health improvement plan. So you can see here that we determined that preventing chronic disease, promoting healthy women, infants, and children, and promoting well-being and preventing mental health and substance use disorders were our priority areas. And then the different focus areas and goals. So then from that, we have a whole plan that's available on our website about the different interventions that that can address these different priorities. And we're continuing to work on that as we've revisited this plan after it being on hold for the most part of this past year due to COVID. So I just wanted to point out that the goal for promoting well-being includes strengthening opportunities to build well-being and resilience across the lifespan, and that this one in particular is where there's a lot of intersection with the work that Office for the Aging is doing, Youth Services, and many of our partners. So just quickly, I wanted to wrap up that our steering committee includes many different partners in the community who, again, all are working on addressing similar issues with the idea of social determinants and health equity, certainly at the forefront. And I think that as we've, all experienced this past year with COVID and the pandemic that, many of these issues are still relevant, but if anything have been made worse or exacerbated by the pandemic, and that as we are moving forward, we're thinking about, what questions do we need to ask or ask differently? What data do we need to collect as we move forward to really address things like structural racism and structural barriers to accessing positive health services and access. So I'll end, sorry, I went a little over, again, with health equity that Nicole had another image of. Sometimes this image is also shown one more step where the fence is actually broken down to represent that social justice piece. And so I'll just reiterate that, thinking about these different issues through a health equity lens is really important as we move forward. Thank you. And I'll pass it over to Ken. Sorry about that.
That's okay. Thank you. Okay, I'm going to go to the beginning of our presentation here. Okay. I need to make one minor adjustment. Okay. I am speaking to this topic primarily as an equity expert, 34 years of experience in faith communities, university chaplaincy, inequity, and diversity and inclusion work in higher education, and now in county government. I'm not an expert on health and wellness, but I will draw on its literature to explore health and wellness through an equity lens. And you'll hear some overlap in my presentation with that made by Lisa and Nicole and Samantha. But before I begin to define equity, health, and wellness, the ideal or what ought to be, I want to discuss what's observable in our own community and others nationwide. What is? Here's a description of health inequity, the what is reality that we face when some have access to rights and privileges and others do not. It creates a context of inequity. And here we find a definition of health inequity. Dr. David Ansel, in his book, The Death Gap, How Inequality Kills, has written that health inequity reflects gaps or inequity in death rates. And I quote from his book here, where these gaps are the result of the healthcare system, they are called healthcare inequities. I prefer to use the term death gaps because it describes the actual outcomes of health equity or inequity. People die prematurely because of inequity. That is, they experience higher death rates than would be expected in the absence of this inequity, unquote. Many people, for example, do not live to a ripe old age or they age prematurely due to health inequity. This slide highlights those who have a lack of access to health and wellness versus those who have access to health and wellness. It reflects who experiences cumulative disadvantage versus those who enjoy cumulative advantage. And we see this, in pretty graphic terms and it reiterates much of what my colleagues have said previously. And certainly is reflective of the social determinants of health. The lack of access and cumulative disadvantage leads to what is called allostatic load. Illustrated here are the intersectional dynamics that impinge on the lives of vulnerable populations. And I can provide another example of this that was captured in a powerful way. On Sunday night, I watched the CNN documentary celebrating the 50th anniversary of late Marvin Gaye's groundbreaking album of social commentary and protest what's going on. And there's a song on that album that captures the impact of allostatic load, I should say. It's called Inner City Blues. And I'm going to play some of that, from that album now. Give me a second. Okay, well, I'm having a little bit of an audio problem, but in this picture, you see the lyrics from Inner City Blues, in which Marvin Gaye sings about hangups, letdowns, bad breaks, setbacks. Natural fact is, oh honey, that I can't pay my taxes. Oh, makes me want to holler, throw up both my hands. And he repeats it again, makes me want to holler, throw up both my hands. That captures the reality of allostatic load in a very powerful and lyrical way. Okay. Oh. Okay, I've got a little bit ahead of myself. Let's see. I'm sorry about the holdup here. And I actually need to go back a couple of slides.
And you might want
Yes.
to, you could try using the back arrow, or you could type the number of the slide you want to go back to if you happen to know, or you could press 1. It may bring you back to the first slide. Maybe
Press 1.
enter.
Okay. Okay. Oh,
Maybe that's not working either. Sorry about that.
okay. Let's see. Let's go from the beginning, and then we'll catch up. And I apologize for this disruption. Okay. Okay. Allostatic load can produce health disparity, which is explained here. The significant difference in the overall rate of disease and sickness, morbidity, mortality, and survival rates in the population as compared to the health status of the general population. Health disparity leads to different divergent outcomes for people, for individuals. And it creates challenges and difficulties for individuals and creates these disparate outcomes in terms of health outcomes that have an impact on people over the lifespan. Now that we have talked about health disparity and health inequities, we can now talk about what health equity is. We've reviewed what is, and now we can talk about what ought to be health equity, or the ideal. Health equity is reflective of interventions taken to address the health disparities we've just discussed. And again, I go back to quoting Dr. Ansel, a society where all the people experience the same mortality independent of race, gender, socioeconomic status, or geography, would have no death gaps. And also it would increase the number of people who actually have the chance to age, that is to live, and impact how they age or impact the quality of their aging. We know that, health disparities, for example, can lead to weathering effects, and this has particularly been the case for vulnerable populations, persons of color, LGBT individuals, veterans, persons with disabilities and such, but health equity provides a different sort of outcome and is reflective of an undergirding philosophy of a commitment to addressing and reducing these disparities. And the idea of health equity was born out of the international human rights movement, which traces its origins to the 1920s, but began to revive in the aftermath of the Second World War. And it was a response in part to address the issues that led to two world wars between 1914 and 1945, two unprecedented global conflicts. And the intent was to equitize on a global scale the rights of every human being to life, liberty, safety, to presume innocence until proven guilty, to allow people to practice the faith or philosophy of life they choose, to free speech, etc. And what became in 1948 the Universal Declaration of Human Rights, which guides the work of our office, in effect confronts the issues that lead to health inequity that contribute to allostatic load. In the Universal Declaration of Human Rights that was adopted by the UN General Assembly in December 1948, there are 30 articles, and Article 25, which is printed here, in particular addresses the issues of equity, health, and wellness. And pretty much speaks for itself in terms of addressing issues of food, clothing, housing, medical care, necessary social services, and other factors, and that people have a right to a certain standard of living and also a certain standard of health and wellness. It is not enough to work for equality in relation to health and wellness, and I promise you I did not steal this from Samantha's presentation, but equality on this illustration, we see how from equality equals sameness, but it can only work if everyone starts from the same place. Instead, we want to get to a place of equity, ensuring that people get the same access to the same opportunities, and that equity makes accommodation for access to resources and make health and wellness possible. Equity creates the conditions for equality, and justice, which is the right ordering of relations, is the guarantor of equity and equality. I want to close with a quote from President Lyndon Johnson's commencement speech at Howard University, a historically Black higher education institution in Washington, D.C. in June 1965, because I think it reinforces not only the message of the previous illustration, but I think, in fact, what all of us in some form have been saying today. And now we'll just read it briefly. You do not take a person who for years has been hobbled by chains and liberate him, bring him or her up to the starting line of a race and then say you are free to compete with all the others, but still justly believe that you've been completely fair. Thus, it is not enough to open the gates of opportunity. All our citizens must have the ability to walk through those gates. This is the next and more profound stage of the battle for civil rights. We seek not just freedom, but opportunity. We seek not just legal, but human ability. Not just equality as a right and a theory, but equality as fact and a result. So I will end there, and we'll move on to the next stage of our panel.
That was a very moving way to end your portion and the portion of all the presentations. Thank you. So now we're going to move to the panel discussion portion. So I invite all of our speakers to turn on their microphones and turn on their videos again so we can hear from you. And I'm going to ask some questions. So actually, I'm going to start, Ken, with you. I was really struck by your saying that the death gap represents many things, but it represents the opportunity to age, or really the barriers to successfully aging and living a complete lifespan, or living a lifespan with health. And that really points to a better understanding of what age friendly is all about, because while we start with a focus on older adults, we're really concerned about everyone over the lifespan. So can you speak more about why it is so important to address equity, health, and wellness as an integrated whole, as opposed to separate inequities or entities rather? Because in this country, we often have this tendency to have things very siloed. So what are the advantages of the integrated approach?
I think, well, because people do not live siloed or bifurcated or compartmentalized lives. I mean, people live whole lives. I mean, there are so many intersections at which people live. I think the illustration of allostatic load by implication kind of highlights those intersections and those factors that can impinge on people, that can impact their health and their well-being, their sanity, their mental health, their emotional lives. And so, one is not separate from those factors. They impinge on the totality of one's humanity, and they impact the mind, body, the spirit, and the emotions. And so we have to look at these because people live at intersections. Kimberly Crenshaw, graduate of Cornell and a major in Africana studies, is a person and who's a well-known legal scholar and also one of the co-creators of critical race theory, has made this, clear that people live intersected realities. They can be Black or white or Asian, but they're also women, they're men, they're gay, they're straight, they're bisexual, they are lesbian, they are veterans, they are disabled. Intersectionality is essential for our understanding of human development and human experience. And so we have to treat these issues in an intersecting way because, allostatic load does not discriminate and does not just simply attack one aspect of one's life, but it can impinge on multiple aspects. And the question is, what kind of systems of care and support and access can we create to minimize that allostatic load on human beings?
That's terrific. Thank you. So would anybody else like to add to that?
I don't have anything to add to it, but I now will be, after this session, listening to Inner City Blues. Thanks, Ken.
Yes. Yeah, I'm sorry I could not play it for you. I had this all worked out when I did my practice run, and then, of course, things go awry. So,
It's okay. We'll all be Googling it when we're done.
okay.
That's
It's
right.
worthwhile. It is my favorite album of all time.
And we all understand about technology, that after all of our experiences. So I'd like to pose this question to the group overall. How are the social determinants of health incorporated into the healthcare system in our local community?
I can start off talking about two things. So in New York State, we had DSRIP, the Delivery System Reform Incentive Payment, which is a 5-year program, which was aimed at supporters providing focus on the social determinants of health for the Medicaid program. So Medicaid funding for providers was linked to process and performance metrics. And for example, providers were incentivized to incorporate, looking at social determinants of health, like do people have supportive housing? So that is one way in which the district program helped to emphasize the importance of the social determinants of health when we're working with Medicaid beneficiaries. Another thing that I know has been in the works in our local community is incorporating the 2-on-1 with healthcare providers. So, and doing social determinants of health screening. And I know that's something that I know some people at CMC are working on. And I recently spoke to someone there who said they did the screening and they were able to identify needs people had and refer them often to 2-on-1 to get them linked to the right resources. So I think we're already making some progress in emphasizing that in primary care and healthcare services, not just looking at treatment, but looking at preventive and looking at a holistic approach to healthcare.
That's terrific. Would anybody like to add to that?
I can add a little bit just to follow up from what Nicole laid out, which really covered much of my understanding as well. But the social determinant screening pilot that's going on and the work that's going on is actually, we've incorporated that into one of the working groups for the Community Health Improvement Plan. And so again, there's just lots of intersection and overlap with the different partners who are involved in that and and interested in seeing the outcomes of how that screener is used locally, and then how we can incorporate it in other, with other agencies as well that, have it in medical offices, but then also, how can the health department and mental health departments be using that kind of screening as well. So I think a lot's going on with that, and just the emphasis on how social determinants are considered and used to inform the work that we go moving forward. And I just wanted to give a shout out to 2-on-1 also, because I mean, during and just this idea of considering all of the different factors that everyone is living with this year, because during the emergency response for COVID in our county, I mean, 2-on-1 has been a huge partner, and that in every phase of this pandemic, whether it was the testing for COVID or making sure that people in quarantine and isolation had what they needed to be successful in that time period. If it's vaccination sites, that we've talked with our different transportation partners and food distribution partners, and 2-on-1 has been vital in making those connections happen. And it's a referral that we're able to give many members of the public to use.
Thank you, Samantha. And I'd like to take this opportunity to thank each of you and your agencies and your departments for the extensive work that you did and continue to do during these extremely unusual and challenging times. Thank you. you know, in terms of the social determinants of health and the importance of these screenings, years ago, I read about a program where there was a community that would give out citations if your yard was in disrepair, the lawn wasn't mowed, or there was trash in the yard. And then someone came up with the idea of instead approaching those properties and speaking to people there to find out what was going on and if they needed assistance. And they developed a training program for young people in the community to come in and do basic yard work and even repair fences and things like that. But they also brought in people from social services to speak to the residents and find out what was going on. And they found that there were a lot of unmet needs. So that that overgrown yard was really a signal to the community that the person who lived there needed assistance. And that was determined. And then the people were put in touch with the correct services and programs. So that's just a real world, more specific example. When we talk about social determinants of health, sometimes they can sound a more theoretical, but that's a concrete example. So another question in going off of thanking all of you for your response in addressing the COVID pandemic, how has our approach to age-friendly planning changed or need to change due to COVID?
Well, I can speak to that somewhat. And it's, you know, a lot of the principles of age-friendly are kind of embedded in what we do in our office. So I think that for us, we completely switched gears on how we actually serve the clients. I mean, nobody was walking through our doors anymore, and we had to switch to things virtually. Well, then there's the barriers that come with virtual and broadband and all those equity things. You know, so to try to, you know, really sift through what people needed and find out how we could get to them. And it was really a case by case basis of what we did. And we're still doing it. You know, what does this person need today, right now, and how can we get it for them is, you know, our motto for the last year, really. Just it completely switched how we do things. But even to speak a little bit to the social determinants piece, I feel like, and Sam mentioned it, that we as a community, we do attend many of the same meetings. We are engaged with, you know, the transportation people are engaged with the housing people, are engaged with the health people, engaged with human rights. So there's like a lot of collaboration that happens in this community all the time. So I feel like it's somewhat natural that we take a look at these things. I just had to throw that out there as well. And it shows in our efforts in COVID. I mean, it shows with our numbers, our you know, vaccination rates, our COVID testing, all that stuff shows and how everybody's pitching into this effort in this community.
I was also going to add to what Lisa was saying in terms of doing things virtually. I think that's something that, you know, actually opens up access for some people. Now, obviously, there are issues with access, you know, especially in rural communities. But I think when you're thinking about like outreach for programs, when you have transportation issues, like having some sort of hybrid option allows to increase access to people who might not have been able to attend events. Or, you know, we're seeing something with like our health insurance navigators, that when they call to make an appointment and I say it's over the phone, they're like, oh, I don't have to like take off a half a day of work to come in. I could just do it on my lunch, you know? So in that way, we're increasing access. And then another thing I was going to say is I think the pandemic has really emphasized the importance of outdoor living spaces. And, you know, because this past year, we've really seen the importance of engaging in the community outside, because, you know, in this point in time, it's the safest way to do that. So really prioritizing those outdoor spaces.
That's a great point. And that is one of the 8 domains of age-friendly communities is outdoor spaces. And
Mhm.
now we're really appreciating the full extent of that importance. I recently read that there are now recommendations that each of us should be spending 2 hours outdoors in nature to counteract not only our sedentary lives, but just all of this exposure to technology. So very, very interesting positive changes coming. Does anybody else want to add to what Lisa and Nicole responded? No? Okay, then I'll move on. So another thing to think about, you talked about data. What data and information do we need to better understand and be able to address structural barriers to health equity?
That's a great question. I'm sure there's more work that we can do around that. I mean, again, some of these required planning tools that we have to use don't always include that specific piece. So, maybe adjusting those tools to try to get that more addressed would be something that we could move toward.
Mm-hmm.
I also find, when, here at Human Service Coalition, when we're talking about collecting data, we have a large percentage of people that don't want to share information. So that really makes it difficult to capture, who we're serving and who we're not serving. And then I think also what I'm hearing a lot from, especially in our health planning council is even once we get the data, like, what do we do next? Like, how do we use that data to address those barriers? So I think that's something that I'm seeing a reoccurring.
Thank you. Ken or Samantha, would you like to add anything about data? Like, is there something that you're really missing that would be helpful to know and understand?
Yeah, I agree. Oh, sorry, Ken.
Oh, no, go ahead.
I agree with Lisa and Nicole's comments. I think that, as we've been, again, sort of revisiting the community health improvement plan after these months of COVID, I think we're just thinking about, and this has been, it's a longstanding issue, is just that the data that we have available from the state, for example, is often, there's a big lag. So just that it's, from several years ago usually. And so, just getting a sense of like, how I'm saying that the community health assessment is supposed to be this like current health status of our community, but that based on data, it's often, it's the source that we have available is often several years prior. So I think that it's just this effort, and desire locally to have a better sense of really what is current. But there are challenges to getting that level of data and getting a large enough sample of our population that's why we depend often on these larger data sets. But I think there's also, many of our agencies, organizations are collecting a lot of information and just how we're utilizing it and what questions we're asking. So again, are we asking questions about, how are our services addressing health equity and racial equity and social justice, and have those questions always been asked? And so it might just be a different way of looking at data too.
I think too, given the fact that there are these sort of lag in terms of the data that's available, I think too, that can be augmented certainly by the stories that people who come to our offices and seek our services tell, which I think in a measure, while not in an absolute sense, an aggregation of data, in the scientific sense, but it is in a measure in the empirical sense. that it's observational. It's reflective in the impact that people experience in their lives. I mean, when they experience various forms of inequity. And so, I mean, and while it may not be a perfect solution to it, at the same time, I think it's another way in which to try to get at the heart of what people are struggling with and what people are yearning for.
Thank you, Ken. Thank you, Ken. Yeah, so different forms of data, getting data more quickly, and having people be more comfortable sharing data and understanding the importance of sharing that data on impacting their own health and equity and well-being in the county, but also everybody else. Because, and that's one thing that, what I often find is that people who are doing the kind of work that each of you are doing, and the work that I'm doing, we do it because it's a calling and we see the need for change. We see the wrongs and we want to right them. But unfortunately, a lot of times what guides decisions is what are the economics? And I think one thing that I have seen in the type of work that we're speaking about is the lack of understanding about how these disparities not only cost the people who experience them directly in terms of quality of life and economics, but how they negatively impact all of us. Certainly in the very least in terms of costs. So we have a couple of questions from the chat. Okay, one was just answered. So one of the questions is about outdoor spaces. Can any of you think of in the county any examples of different things that have been done related to outdoor spaces in the pandemic, making them more usable for people or more welcoming, any kind of policy changes?
Yeah, I'll just say, one of the things that we have done through our age-friendly work and even through the Center for Excellence is different groups, students, and different people on the steering committee have really highlighted some of the best practices that were happening during the pandemic. And they weren't all related to outdoor spaces, but I think, we haven't necessarily done the work, but identifying what's happening around the county is something that we're always interested in. Local businesses have done certain things. Restaurants have done outside. We closed down a street and have outdoor dining. There's things like that. But I think that there's also things that, like the city of Ithaca, this is just an example of the snow angels. I don't know if anybody's familiar with that, but they've had students create an app. It's like a gamification app of trying to have people get, points to like shovel off curb cuts in the winter or identify places where there's problems on the street and things like that. So, creating things like that in a pandemic I find it interesting. I know that there's been a couple people that have approached us about some grants that they were looking into to more signage for people to make things more walkable, to understand what, directions where things are downtown, just little things like that. Although they're not coming from the work that we do directly, knowing what's going on and engaging with other organizations or agencies to find out what's happening is, I think, something that we really appreciate doing as part of Age Friendly, just to highlight it, identify it, and work together on it. I'm sure there's other things I don't know.
Well, and I was just going to add to what Lisa was saying. I know that the Human Service Coalition and the Finger Lakes Independent Center were working with some Cornell students who were looking at, like nursing home populations and issues of preventing falls, but also isolation and getting people outdoors. So I know there was a group of Cornell students that worked on mapping walking paths that were accessible. So that was something they actually just presented on, I believe it was last week now. And that was what they were looking at, both urban and rural communities as well. And then there's also another group of students who are working on updating the city walking map. So that's another thing, because there's such an emphasis on those outdoor spaces.
That's right. Thank you, Nicole. And those reports will be available on our website in a few months when we have them up. So actually, maybe even a few weeks. So I would like to close this section with a question for Lisa, and then Lisa, you and I will move to our closing remarks. Okay. So Lisa, how do we continue to incorporate age-friendly practices into programs at the Office for Aging?
Sure. I think we've even pointed to it in some of the conversation that we've had here, but one of the things that we do in our office is continually collect information and feedback from the clients we serve or from the community. Not just the older adults themselves, but the caregivers and the people that are caring for older adults, to make sure that we collect information on unmet needs. Unmet needs is a huge list that we have that we keep all the time, and we even receive funding that tries to address these unmet needs of these waiting lists. But staying engaged on these various committees and boards and all interacting with each other, I think, is an important thing in our age-friendly work. So we know what each other are doing. That's a really important thing for us. But on a broader level, supporting advocacy that is being done, like, for example, right now, the state is looking at doing some advocacy around modernizing the Older Americans Act. I mean, it's an antiquated act, that doesn't always allow our funding to be used for what it needs to be used for. I mean, just an example, we receive funding through the Federal Older Americans Act for Title III C1 funding for congregate meals. So nobody's really congregating right now for congregate meals. So luckily we're under a major disaster declaration and they lifted that, but going forward, things have changed. And are we going to go back to that? Or can we use the funding for what our community actually needs? So, having the flexibility to meet what the needs are of the community rather than attempting to fit the community into this regulated, prescribed funding is important. Ensuring the flexibility on the grassroots level, meeting those needs that we identified during the pandemic. Those are really important things that in my locally, statewide, that we're trying to really change, because it's certainly an outdated act at this point. And I think moving forward, we could use some of this funding to address some of these concerns. More social determinants, some of those age-friendly practices we could embed further into our work that we do on a daily basis if that funding was more flexible. So.
Thank you. Okay, so now I'm going to change gears and I'm going to share my screen. Okay. Lisa, one slide.
Looks good.
Okay, great. So Lisa, are you ready? You want to share your closing remarks now?
Yes, it's just short and sweet for me. I really just want to say thank you for everybody that has attended this, and for those of you that will attend in the future. We'll be putting up a survey in the chat. Please complete that. The people that were attending today, we will send that out to you. And this will help guide our age-friendly efforts of the future with our steering committee as we wrap up this series. We will be having a little celebration. I think we are hoping to anyways, and taking the summer off and reconvening in the fall and trying to figure out, you know, where we're moving toward. And Esther, you could probably speak to this just as much as I can. So I'll let you take that too. You know, all the information on here is going to be recorded. We will most likely revamp our website a little bit to make it a little bit easier to navigate the resources on it. I hope to, you know, create like a repository of information for people that they can jump on there and look under, you know, a broader category and find those tools that we've established through the Center for Excellence. And just hope that people will use the information, and we'll move forward and keep doing this good work.
That's great. Thank you, Lisa. And thank you for your leadership on this. So for those of you who don't know me, I'm Esther Greenhouse, and I'm the Strategic Director for the Tompkins County Age-Friendly Center for Excellence. And this Age-Friendly Center for Excellence was funded by a grant from the Health Foundation for Western and Central New York as part of a public-private partnership with the New York State Office for Aging. I'm thrilled that everyone has joined us today and hopefully throughout this virtual workshop series. If you were unable to attend previous workshops or you would like to revisit them, again, the links to the recordings are on our webpage. I also want to thank two people, actually three people. I'd like to thank Karen Bullis, who has we would not have any information on the website if it were not for her efforts. I'd like to thank Vanessa Wagner, who has been our intern, for all of her support and assistance. And lastly, Dominic Recchio, because I don't know how we would have managed Zoom without you. And in addition to the recording links being on the website, we also encourage you to visit the website training page, because we have resources there and we'll be adding additional resources. And there are also links to the extensive resources on the AARP Livable Community's website to further your work and your efforts. So to build on the successes to date, we are looking for greater involvement from the community, particularly in our quarterly steering committee meetings, which will reconvene in the fall. When the while the age-friendly work has been going on for over a decade, the COVID-19 pandemic has dramatically shaped everyone's lives and will have long-term impacts on municipalities, agencies, organizations, businesses, services, and of course, residents. Prior to the pandemic, when I worked with municipalities, I always presented the age-friendly program and the enabling design approach as unifying frameworks for addressing seemingly disparate and competing needs. Now, due to COVID-19, this framework is more important than ever. As we begin to explore and understand what we can do with the coming resources that we will potentially receive from the American Rescue Plan, we must continue the goal of New York State Executive Order 190, that's health across all ages and policies, and ensure that an age-friendly lens overlays all that we do. We cannot prepare for a successful post-COVID recovery without considering and meeting the needs of the over 50 population and their families and the organizations and businesses which serve them. And we must remember that age-friendly may begin with this population, but encompasses all ages. We must and we can harness the opportunity to create communities that enable people of all ages to thrive across the lifespan. Thank you all so much for participating. Thank you to our speakers today. And please, again, check back on our website for additional information.
Thank you all.